Hello, Dr. Gellman. I'm so happy to have you on. Welcome. So, everybody, this is Dr. Rosie Gellman. She is my go-to psychiatrist in the town of Boulder, Colorado, the state of Colorado. She has a unique background. She is both a pediatrician, a child adolescent psychiatrist, and also an adult psychiatrist. She completed her undergraduate education at Duke, her pediatrics residency at Baylor, and child and adult psychiatry training in the Medical School of Georgia at Augusta. So very well credentialed, very well established, and has a thriving practice here in Boulder, Colorado. So today we are going to talk about the very tricky and very important topic of pediatric suicidality. We are going to split it into two parts. The first part is true suicidality questions, and the second part is suicidal threats and suicidal ideation that is related to anxiety disorders, OCD, or personality disorders. So, welcome.
Thank you for having me. I'm excited.
Yay. Okay. So we know we are talking about a very heavy topic, but as mental health professionals, we talk about it very casually, very openly, and we're very careful to destigmatize talking about suicidality. We really believe that it's important to do so. So to start off, Dr. Gellman, what is your most go-to protocol for medically treating cases of suicidality?
So, unfortunately, we don't have a medication itself that specifically fixes suicidality, especially not in kids. There
Mhm.
are two different medications that actually do lessen suicidality itself. But they're not medications we use often in kids, and they're not medications we use often, especially for things like anxiety and depression. So those would be lithium and clozapine. Probably never heard of them. They won't cross your radar very often, but those are the two we've got. Other than that, I pretty much digging out and looking for the underlying cause of the suicidality. Like, what is really troubling that kid enough that makes them want to not be here anymore? And so, as with any child, they come in themselves and the families, and we talk it out. So, we talk about what's going on in life. We talk about what the big stressors are. We talk about why there isn't that hope for the future and try and find a hope for the future too. Yeah, so a lot of it is based on kind of that history. And then we work to treat the underlying issue. So whether it be depression, anxiety, OCD, psychosis, that kind of thing, that's what I'll use the medications for. And then I always want my patients in therapy as well, so that they're
Mm.
really working a lot deeper on this stuff and spending a lot more time trying to find those sources of hope, working on ways to keep themselves safe, skills to get themselves out of these really low periods and episodes that they may experience. So I'll work with the patient and kind of review that in session, and I'll work with the therapist as well. Especially if we get to some of these more crisis times, I'll be more in touch with the therapist. I'll bring the patient back, patient and family back for more frequent check-ins if we're kind of in one of these lower, more crisis type modes. So even up to a few times a week, just to check in, have eyes on them, talk, see where we're at with some of these thoughts, and make sure that everyone's staying safe. And then with everyone, I do set up a safety plan. We go through and we write it out so they have something to pull out if these thoughts do worsen. And if we need to, we can always refer out to a higher level of care. But I try and do as much outpatient and in my office to keep kids from going to some of those more intense settings if possible.
Absolutely. So I can personally attest to Dr. Gellman, among the psychiatrists I've worked with, you are among the most communicative with the therapeutic team, which I deeply appreciate. If you're listening, make sure that your psychiatrist is in communication with your child's therapist. That is so helpful for everybody. So on that note, in terms of communication, how is it that you partner with parents when there is active suicidality?
So with any concerns of suicidality, my like confidentiality with that patient alone kind of goes out the window, unfortunately. I tell them I'm sorry, but my ultimate goal is to keep you safe and keep you here with us. And so if you tell me anything like that, I'm going to have to bring your parents in as well. And we're all going to talk about it together because we want to keep you safe. And so we bring everyone in, if any kind of concern arises, either brought up by the parent or the child, and we sit down and we figure out a way to keep the kids safe. So like I said, we'll write out a written safety plan. We go through things like the thoughts they're going through in the moment, going through their head, feelings, work through their coping skills, write it all down so they have something to pull out, write down who they're going to call or who they're going to talk to. Everyone gets the crisis number, the crisis resources, both local and the national one. And then resources if they need for like a higher level of care, an emergency department or something, if they need to go that route. And that's all in writing. I have them posted around their house, a refrigerator. They have their own copies. They don't have to ask for one. They have those numbers programmed in their phone already. So try and kind of catch it from every aspect, and then make sure the parents are doing everything they can too. So we'll look at kind of risk factors at home, if, lock up medications, try and keep the child out of the room and engaged with the family, keep them on the couch in the living room around people if possible, take away sharps, definitely firearms. That's kind of the leading risk factor out there. If there's firearms, especially if they're loaded in the home, that's one of the biggest risk factors for a suicide attempt and the completed suicide. So even in pediatrics, we were talking about this with patients and parents all the time too. But yeah, I just really want everyone involved. I want all questions answered. I want, when this stuff arises at home and I'm not there with them, everyone to know what they're going to do, basically.
Awesome. Awesome. That sounds amazing. That sounds like a very intensive outpatient experience. So as you said earlier, the desire to keep a suicidal teen from being separated from their home, taken out of their friend group, out of their school environment. So trying to treat suicidality safely in an outpatient setting, it requires a massive commitment for all the practitioners and the family who are involved. So on that note, how do you suggest parents balance safety and trust with their suicidal child?
It is so hard because you don't want the child to feel like they're living in a prison either. You want them to feel comfortable and safe. It's their home, their family. But once again, like, we got to keep them safe. And so I say, if we're having these thoughts, we want to do everything we can to safeguard you from yourself, from your thoughts, from the environment around you. And so we might have to lose privileges for a while, and we'll work on earning them back. We want you to get back to normal life. We want you to be a normal kid. But some things like spending extra time in your room or extra time on your phone, we know just aren't really good for your mental health typically. And when you're already in a low state, we don't want anything to get worse. And so we will have to lose some of that stuff for a while, and we will slowly add things back as we go. So that's kind of what I start with. I mean, some of the obvious ones, you got the firearms, the medications, parents managing medications, and just spending more time around people. Kids get pretty sensitive about their phones these days, but phones are tricky. Once they're kind of going down that depressive path, those algorithms will catch them and they'll throw more of it at them. And so oftentimes it's better to limit a lot of that in the meantime, and they can slowly earn it back and get there. And just kind of reassuring them that we're working towards normalcy, but unfortunately, like, safety is our top priority here.
So what I hear you saying is safety over normalcy.
Safety.
Yes.
Yep. Safety.
Even if it causes some conflict between parent and child, in your eyes, that conflict is worth maintaining as much safety as possible.
Yes, and it's pretty much guaranteed to cause conflict, I would say, because you're, violating what they consider to be their rights and their own personal boundaries. But it's all about safety. And that's why I do so much while they're here in my office, is because I know some parents, it's hard to tell your kid no, especially when they're already feeling low and feeling down. But I want the parents comfortable doing so and to know what they're going to say and know what they're going to do when it does come up. So we rehearse it, we go through it, so everyone's ready for it. And we'll give it back to them as we feel like they can handle it, but safety, 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 safety.
Absolutely, absolutely. And I find it useful to talk with clients about what residential actually looks like, not to scare them or anything like that, but just to understand that like we're doing a very light version of the protocols that do happen in residential, and there's a reason for them. So limited communication is actually a big part of residential treatment. So awesome. Well, I want to move on to something super duper tricky. And y'all, one more reminder, this is not for true suicidality. This one is for suicidal threats. So the weaponization of suicidality. In other words, buy this thing for me or else I will kill myself type of dialogues. And then on the other hand, suicidal ideation or suicidal fears that are not actually linked to true danger. So these are two different things, but neither of them is suicidality. So I would love to talk with you about, how we might differentiate, how we might approach it. So let's start with what is the difference between suicidal ideation and true intent in your view?
So I almost expect people to have had some sort of suicidal ideation at some point when they've been frustrated or depressed or overwhelmed. It's fairly common. There's a survey that goes out to teens every year, and it showed that just the thoughts of hopelessness are in about 40% of adolescents. I'm guessing it's way more because I know most adolescents and adults have been there before. And just the thoughts of, I can't do this, I can't go on anymore. It'd just be easier not to be here. I mean, it's probably popped into all of our heads at some point. And so that's kind of the ideation, is just the thought, like, what would it be like if I weren't here, if I didn't have to do it? Maybe it would be better, maybe it would be easier, that kind of thing. But usually it passes. Like once you're out of that phase, typically it goes away and we realize, life is worth living. There's hope, things will get better. Intent comes when you actually plan to act, like you're thinking about actually doing something to end your life. And that's when I get concerned if there's an intent, a true intention or a plan to actually end your life. So that's when things get a little bit more serious. Hopelessness is a really big risk factor for that. So just a feeling that things are not going to get better, that you're just going to be stuck for a while, that you're a burden to someone else or to your family, that people would be better off without you here, and that kind of thing. And so you're really thinking about acting on this, you're playing it out in your head, kind of thinking about when you do it, how you do it, and that kind of thing. And that's really when we start, more aggressively safety planning, bringing you in, thinking about referral and that kind of stuff. That same study had showed that there was a plan present, in 20%, 18% of adolescents. And so it is still pretty common to have that come up, and we just bring them in and we talk about risk factors and do what we can to keep them safe once again. I think
that's a really good distinction. So, normalizing both ideation and true intent and suicidality. So understanding that these are things that, 20% may experience having a plan, and that does not mean that doesn't need to be taken very seriously. It definitely does. But also understanding that there are protocols for this and there's precedent for keeping kiddos safe, even when that is true. Awesome.
Yeah, and we can still do it on an outpatient basis. It's not just because they have that plan there, they need to go straight to the hospital or anything. We can come in, we can check in more frequently and make sure we're keeping everyone safe. And work to just kind of find a hope again and a reason to live. But that's when we start to really, take things a little bit more seriously and step it up. Because these thoughts can be there for a while. We call it also a differentiation between active and chronic. Suicidality is another one we have. And so if those thoughts are there, they're kind of newer, they're fresher. The plan is there, we start to get a little bit more worried. If it's chronic and it's been there, they've had these thoughts for years, even if kind of the plan has been there for years, but they've never really shown that intent, they're going to do anything about it, we don't often worry as much about it. in those cases.
Thank you for explaining that. I've actually never heard those terms, active and chronic suicidality. Thank you so much. So, how do you distinguish between harm OCD, suicidal thoughts? That's my department over here in the OCD clinic, and truly dangerous suicidal thoughts. What is the difference as you see them?
The harm OCD thoughts, they use that term, I'm sure you use this term a lot, like ego dystonic. It doesn't really seem to match like the values, the mood, the mindset, the goals overall of that patient. It's more just they're really worried about these thoughts they're having. They don't want to act on them. They don't want to do anything about them. The thoughts are just there and they don't really have control over it and they don't really know why. And the thoughts are really, really troublesome for them. With more true suicidality, sometimes those thoughts are a little bit more calming for them. Like they have this end plan, they're depressed and they feel like life really isn't worth living anymore. It may be better off actually if they were to act on something like that. So it matches more a lot of what you see with their general presentation overall. Like they typically are depressed or anxious. They feel that hopelessness. Yeah, just not really future oriented where they can't even get themselves to think about going through life on a day-to-day basis. And the thoughts honestly are not as troubling to them, unfortunately, as they are in like that OCD where the thoughts just replay and replay, and they're worried about how to get those thoughts out of their head.
Yes. So what I hear you saying is that on one hand, they're alarming thoughts if it's OCD, and on the other hand, they might be calming thoughts if it's true suicidality. That's not, always necessarily the case, but in general, it sounds like you do not want to be thinking about suicidality when it's harm OCD. You're actually kind of disgusted or worried or like truly concerned that something bad might happen, rather than actually sort of fantasizing about something bad happening.
Yeah, that's exactly what I hear from patients too. A lot of what I know about all of this stuff is what I learned from my patients. So I think them being the best teachers, but yeah, those are some of the words I've heard them use.
Yeah, awesome. So last question, and this one is, I guess, probably the ickiest situation, but how do you discern if a child is using suicidality as a threat and as a manipulation tactic?
It is so hard, and it's so hard to know at what point to act on it as well. Because when you say this stuff, there's consequences even just to saying it. If you say it to the school, they're going to send you for an evaluation, either outpatient or oftentimes directly to the emergency department. And so it's kind of hard to know where to draw the line with it. And it is so rampant. I'm not sure why or when it started becoming so rampant. I guess in the past 5 years, I've really seen just these things coming out of kids' mouths and at younger and younger ages, preschool, elementary school kids, just saying that they're going to kill themselves if they don't get something their way. And it's really, really troubling and like hurtful for me to hear a young child say those kinds of things. And so it really comes into looking at like the behaviors and the environment surrounding the situation. So I love looking at, like we call them the ABCs, like the antecedents, the behaviors themselves, and the consequences. So looking at what's going on before this kind of behavior occurs. I mean, even in true suicidality, not just when we're suspecting manipulation, but looking at what's going on in the situation before this comes out of their mouth. Oftentimes it's a loss of a privilege or being told no. The phone being taken away really gets kids these days. So honestly, that's the biggest trigger I see for this. And then the behavior itself. So I have everyone paint a picture of what this looks like, what this episode looks like for me with their words so I can really picture it. And then the consequences. So what happens after they say this? Do they get the phone back? Do the parents run over and love them and hug them and kiss them and they get like really positive attention and feedback? Are the parents just yelling at them more and more and more once they hear them say these things? So really kind of painting a full picture and looking at what is driving this behavior. If it gets to the point that, like I said, that they're saying it and doing it at some point, you're going to have to act on it. And so sometimes just taking it seriously, even if you don't think it is seriously, is enough to drive down the behavior. So taking them to someone like me, taking them to the emergency department, getting someone else involved so they see the natural consequences, like what's going to happen in the real world if you say these kinds of things. You're going to get evaluated. People will take it seriously because people are worried about your safety. So you can't just run around saying this stuff. And so at some point I will encourage parents to start doing that, even if we think it's not someone with a true intent, just to show them what happens. I talk to them what it's like, about what it's like you said, in the residential facilities, even in the acute inpatient facilities, even in some of these like partial programs where they're just going 3 times a week. Kids don't want to go 3 times a week. They want to live normal kid life. And so just try and find a way to make them realize, like, this is a real problem. This is really going to affect your life if, this is something you're considering, and this is what it looks like to help you get better from having these kinds of thoughts. And so sometimes that's enough to help kind of mitigate some of these behaviors too. But I hate that one. It's hard when a kid is saying these things, whether they're real or not. Like, these are powerful words. And so it's hard not to react and to kind of know what to do in the situation.
And just want to send out so much empathy for parents trying to differentiate between true suicidality and suicidality used as a threat. Like, you're probably, as a parent, in your amygdala and not actually thinking rationally or evaluating with your wise mind. So, bring in a professional, act as if, I totally agree with Dr. Gellman, act as if this was true. Act as if this was actually suicidality and do anything that you would do if you believed that. And then the truth will come out in the wash, is how I coach parents, and totally agree with Dr. Gellman's strategy. And also notice, I want to ask, what is the function of that statement? So if somebody says, I'm worried about my safety, like I'm having all these suicidal thoughts, the function of that statement is to get support to get better. If someone is weaponizing the concept of suicidality, then it very clearly has a different function. So Dr. Gellman, I am just so appreciative that you spent this time with me and our listeners talking about this very difficult subject of pediatric suicidality. I wish that I could clone you and there would be like 20 of you at least in every state, but we're lucky here in the state of Colorado that we have Dr. Rosie Gellman. She is available for consultations in her private psychiatry practice called Psych for Tykes and Teens here in Louisville, Colorado. Thank you so much for being on with me, Dr. Gellman.
Yes, thank you so much for having me and for talking about this stuff, because I know it's hard out there for kids and parents alike. So thank you.
Appreciate you. Bye.